Okay, hello and welcome everyone to today's webinar, Post-Traumatic Stress Disorder, PTSD. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Amanda Barnett and I will be the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask that questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay, along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in the planning of our educational resources. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, a certified case manager, certified nurse life care planner, nurse life legal nurse consultant, and certified health professional life care planner. She has worked as a nursing professional for over 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medical legal services, including life care planning and ancillary professional nurse consulting services, as well as vocational expert witness services and case management. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the Universal Life Care Planner Certification Board. She is also an active member of the Association of Rehabilitation Nurses, the International Association of Rehab Partners, and the Case Management Society of America. At this time, I'll pass it to Cynthia Bourbeau.
Hi, thanks, Amanda. First, I'd like to share a little bit about the Injury Insight program. So Injury Insight is a 4-part webinar series designed to educate claims professionals, human resource professionals, case managers, physicians, other healthcare professionals on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments, both common and uncommon, within workers' compensation and general health care. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer all of your toughest of questions. So as always, get those questions ready. So for this year's 4th and final Injury Insight session, PTSD, we're pleased to have Dr. Tabitha Mariano to present for us today. I'd like to just say thank you before we go any further and I introduce her. I personally met her through a referral with a patient and was impressed with her program. Obviously, in this day and age, this is a very much needed area of healthcare. And so I think that her services are very much in demand. Today, Dr. Mariano will draw on her extensive experience working with first responders, veterans, and trauma survivors to discuss trauma-informed therapy techniques like eye movement desensitization and reprocessing, EMDR, and how they support individuals with PTSD, traumatic brain injuries, and co-occurring mental health challenges. This session will also cover our approach to critical incident stress management for crisis response, highlighting the essential roles of compassion and resilience in trauma recovery. Dr. Majorano has over 22 years of experience in mental health, working across psychiatric, forensic, and community settings. She holds multiple certifications, including licensed clinical social worker, certified co-occurring disorder professional, and certified traumatic brain injury specialist with a PhD in public safety leadership from Capella University. Dr. Tabitha, she gave me permission to do this because I was killing her last name. So she specializes in treating mental health and substance use disorders, trauma, and traumatic brain injuries. She is trained in-person centered planning and therapies such as EMDR, DBT, and motivational interviewing, focusing on individualized care for diverse client needs. Dr. Tabitha served over 18 years with the Connecticut Department of Mental Health and Addiction Services, including as a crisis intervention team clinician working with law enforcement. She is now the owner of TD Forensics LLC, where she provides specialized training and consulting for first responders. She is active in mental health support for first responders and volunteers with organizations like the Red Cross and Brain Injury Association of Connecticut. So thank you again, Dr. Mariano, for being here. And with that, I will turn it over to you to begin.
Thank you so much, Cynthia. Let me try to share the screen here. And let's see how we do. Is it working on your end, hopefully?
Yep, looks great on our end. Thank you.
Okay. So yeah, good afternoon, good morning, depending on what time frame you're in and where you're living. It's wonderful. I would like to say it's wonderful to see people. I was joking before this started that I am somebody who kind of likes to teach in person and Zoom around the room and pop in and pop out. And so I feel like I can't see people here. So for me, that's a little bit stressful, but I'm hoping that if you guys have questions, concerns, anything I can highlight or expand upon, there'll be plenty of time at the end so that we can do that. I made sure of that because I want to make sure you get your questions answered. And yes, I was thankfully asked to come here and talk about some of the work that I've been doing and others like me have been doing, discussing some things about trauma and wellness. I worked many, many years for the Department of Mental Health and Addiction Services, as Cynthia said. And with that, I originally started seeing patients like anybody else and seeing, people with co-occurring disorders and people who were just really indigent and had severely mental health issues, traumatic brain injuries, all sorts of mental health diagnoses, substance use diagnoses. And I did that for many years. And with that in Connecticut, which is where I'm out of, we had a program called the CIT program. And with that, it's a little different now if you know of it. But back in the day, when we weren't so restricted, I was embedded in the police department. So for over 12 years, I was embedded. I rode around with cargo pants and a bulletproof vest and went to every single call that they went to and interacted with everything. So I have been in the middle of everything. I ran some mobile crisis. And with that, I realized that a lot of first responders need help too. I grew up in first responder world. My father was a chief of a fire department. My mom was a trauma nurse who taught and did all sorts of stuff. And the rest of my family was police. So I knew the need was out there. And so I started to open up a practice and work solely with that while I was still at DEMIS. Eventually, I finished up my time at DEMIS and now I just have the practice. So I see first responders all day long from 7 in the morning till 10 o'clock at night. And people laugh and ask me why. And I say, because if you're going to do trauma work, you need to meet these guys where they're at. And they are at shift work. And when they come in at 8 o'clock at night, having their dinner with me and getting ready for midnight shift, that's what we do. So I see them and I teach at some of the local academies and kind of all over. So that's a little bit about me. But I wanted to work on the things that we were told that we were going to talk about today, right? We kind of discussed, you signed up for, you wanted some insight on. So let's look at some of the objectives. We're going to look at some of the trauma and also the wellness stuff and some differences between both. We're going to look at co-occurring treatment, some of the challenges that go with this co-occurring treatment and how we're doing with that. We're going to look at trauma-informed techniques. I know they spoke earlier, they mentioned the EMDR, they mentioned DBT and motivational interviewing. There's a host of different trauma treatments that work for people that suffer from PTSD or people that just suffer from depression and anxiety. But we're going to talk about some of them. And we're going to work on looking at some of the crisis response. And I do think the crisis response is going to be different for those first responders versus others. So we're going to look at that as well. And then we're going to talk obviously about resiliency and recovery. What kind of treatments work? What's going to be helpful? What's going to move us forward so that people can get well? Our goal for everybody is to get well. That is our goal. Our goal is to not keep people in treatment forever. I always tell people that, I am not a therapist when I am being a therapist who wants to keep people forever. That's not my goal. I want to give you tools. I want to give you things to make you feel better. And I want you to be able to get on with your life. The goal is not to stay with that therapist forever. When I see a new patient who comes to me and tells me they've been with the same therapist for 5 years, 10 years, I had a lady that told me 20 years. And when I asked, wow, that's awesome. However, what's been working for you? What's working? What's not? And she looked at me and said, well, they told me I needed to come and I have a good cup of coffee with them. I don't really know. Okay, it could be helpful for her, but I want her to learn the tools that she needs so that she can be successful. She can build up that resiliency and she can recover. So we're going to look at this stuff. When we move forward and start looking at support for all, I feel like we have the community at large. We have people that suffer from severely mentally ill illnesses. We have people that suffer from substance use. And then we have the co-occurring, which has people that suffer from both, right? They have a little bit of this and a little bit of that all mixed in together. When I talk about first responders, as I'm going to focus on today, as we discussed, I look at the whole skew of everybody. I think one of the main, I don't know if it's problems, but one of the main things that I see in the community is that people don't know how to even distinguish first responders. They get caught up. Some people think it's only police. Some people think it's only fire. People get caught up on the names. They get caught up on the titles. They get caught up on the disciplines. And they sometimes don't realize that there's a lot of people to include. So we want to look at EMS and EMS as a whole. You've got your EMTs that are there. You've got your paramedics that are there. We have fire. We have a lot of people that you will see who joined the fire world because they wanted to fight fires. The problem nowadays is that most of the fire departments are embedded with EMS. And so a lot of them are the first responder for EMS and for medical. And while that's great and it's wonderful and they do a great job, some of the people that signed up are starting to wonder why they signed up. They're starting to tell me in therapy, I wanted to fight fires. I didn't want to go to cardiac arrests. I didn't want to do these other things. And now they're on an ambulance. They're on a rig. They're doing other stuff and not really seeing all their fires. It's going to play a role when you're treating them and when you're looking at their traumas, because they now are working in a field that they perhaps didn't necessarily think they signed up for. So that becomes a big thing when you're looking at fire and EMS. You have police, and I tell people a lot of police and fire and EMS, they forget about their dispatchers. We know that fire and police have a huge toll. We know what they see. I've been out there. I've been on the streets for years with them. We know what they go through, or we expect or think we know what they go through. People forget about dispatch. People always forget that dispatch is a first responder as well. They forget when you're looking at trauma that the problem with dispatch is that they don't get closure. There is absolutely no closure in their world. They hear everything. Everything is audio. Everything comes in as audio. When they have PTSD, if they do, their flashbacks, their remembrance of things is audio. And then they make up the scenarios. So if you think in your world and you think of whether your spouse comes in the room or your child comes in the room or a coworker comes in the room and they want to tell you something interesting or tell you a story, you start listening to the story. But as you think about it, you start to picture what those people look like. You start to picture what they do, how they act, their mannerisms, and you can be completely way off base. But you don't know that because you don't get to see them. So dispatchers kind of make up stuff in their head, not on purpose, because that's what the brain does. So they have these false memories that come up at times, and they don't get closure as to what happens on the calls. Corrections, people often forget about corrections as being a first responder. Corrections is lumped in with them. Corrections is in a building. Your officers there are in a building 24/7. They work long hours, extra hours, and they have no windows. They have no escape. They go every single day, the same people, the same things over and over again. So they have a different type of trauma. They have a trauma about waiting for the unexpected. waiting for that raid, waiting for those bells to go off, waiting for that inmate to possibly act out. It's completely different. Now, most people think about trauma and they think about first responders and they think about military and vets. But that's a thing you have to really think about, how they come back from whatever deployment they are on. Or, as someone I had earlier this week was supposed to go on deployment, was set, had got their entire life ready to go, had set everything up to leave, and then it got canceled again and postponed. And what that did to that person's psyche, thinking they were going, expecting they were going, setting up their lives as if they were going, only to have it canceled. And you have healthcare workers. A lot of times people don't think that healthcare workers are first responders. I get people that call me all the time and ask, I'm a nurse in the emergency room. Do I count? I work in the operating room. Do I count? I'm in ICU. Do I count? Yes, they count. Yes, they're seeing traumas every day, over and over again. And one of the things to remember when you're treating these people is that we are very good at compartmentalizing. And I mean very good. So we learn to compartmentalize over and over and over again. And I tell people that they seal up their boxes with duct tape. The problem is several weeks, months, years later, the duct tape starts to leak and they start to have an issue as everything starts to seep out. So you're going to see these as people that are in need of assistance. They're people that need care. They need treatment. They can and will get better, but they are also people that stay within their own culture and they stay within their own means of people that they know and people that they trust. And so it's getting together and creating that network of people that treat them, who they trust, and who the treaters trust them. With that, the additional tools that people don't think about that you're going to see when you start looking at treatment and moving forward for first responders, not only family and friends that we're used to seeing, but chaplains, clinicians who are now embedded with them, and now the comfort and support dogs. We have a lot of them specifically in Connecticut where I'm at, whereas they go to those CISM responses. When you're talking about having responses and crisis response, when they're doing debriefings, when we're doing diffusings, when we're going there after a critical incident, we're bringing all of these people because you want to know who is going to be helpful for them. And what helps one person isn't necessarily going to help the other. So all of these people play a part when moving forward to treating first responders and looking at who the first responders are. Common presentations that you're going to see with these people, I don't want to keep saying guys because it's guys and girls, but this population, substance use, huge. We're going to talk about that in a minute. Huge, huge, huge with substance use. They are at a 3 times higher rate of substance use than the general population. That in itself is humongous. The old school thinking of peer support, beer support, as we call it in my world, doesn't happen anymore. Now they're just full-fledged using. They're using different things from their doctors. They're using things that they order online, thanks to telehealth, all sorts of things, which we'll look at in a minute. Their depression rates go up. Their anxiety rates go up, and all of it with trauma. Again, they have overabundance of trauma coming in all the time. And their body is always on high alert, waiting for that trauma. So when we look, they state, and the people, the researchers, the world, the people that put all these numbers together, and I take them with a grain of salt, depending on who did it and where it comes from. However, they're talking about 85% of people who are first responders have experienced mental health symptoms. That doesn't mean they need to be inpatient. It doesn't mean they need to go away. It doesn't mean they need to be taken off their job, but it means that they're having symptoms. It means that they're hurting. It means that they're struggling. And it means that we need to work with them to help them, to have them succeed so that they can build up that resiliency and they can move forward. I'm sure most of you have seen this window of tolerance picture, especially if you're clinicians, healthcare providers. You've seen it in some book, in some place, somewhere back in one of your earlier days in school. For first responders, we say all the time that they live in the top part of that window of tolerance. They live in that hyper arousal. They're always ready to go. always moving, always ready to act. Now, that's good for their job. It keeps them on top of things. It keeps them vigilant. It keeps them for protecting us. It keeps them to help us a lot. However, it also is very taxing on their body. So if their body is always in a hypervigilant state, if they're always ready to go, their body can't stop. Their body doesn't slow down. It doesn't have that off switch. Now, on the other side, if they start really having a lot of depression and a lot of anxiety, what you're going to see with them instead is the hypoarousal, the bottom part, where you're going to see the depression increase, the despair the increase, all of that, where they become sad, they become sluggish, they don't have energy, they're exhausted, they're tired, all of which starts to come. We'd like to keep them in the middle. We'd like to keep them right at that even balance in the middle. However, doesn't happen a lot with first responders. They stay up high, they bounce down low, they go all over, and then they either end either extremely high and that's where they live for a while, or extremely low and that's where they live for a while. Either way, not helpful. For those of you that are aware of the ACEs scale, the Adverse Childhood Experiences scale, a lot of you have used, this is a scale that clinicians use at times, which is a questionnaire for patients that help get a sense of what has the person been through before the job, before they came into the office, before they came to see me. Now, that's going to be important when we talk about EMDR, because what they're learning is that those things that we learn in childhood, whether it's I'm a failure, I'm no good, I'm not worthy, I'm unlovable, all of those things play out later. So for first responders, you're going to see that they're sent to you for that TBI. They're sent to you for that car accident. They're sent to you for any of those acute things right now. But when you actually have to work to fix the symptoms and the behaviors that they're expressing, you actually have to go back sometimes and work on the childhood stuff. And that will kind of get you more bang for your buck, as I call it, because you're going to fix a lot of things and you're going to fix the brain so it stops thinking illogically and starts thinking logically again. And we're going to talk about that after. So for them, I kind of joke and I talk about this struggle bus. I had a client who once told me that she felt like she was always on the struggle bus. She was always trying to keep moving and moving with the struggle bus and she couldn't keep moving. And I told her it's like the teapot. A lot of people use the pressure cooker as an example. I've always used the teapot because a teapot, you can't see inside. And for me, I feel like everything that we've gone through day in and day out, whether it's at home, it's at work, it's with our family, our kids, whoever, it's always one more thing, one more drop of water. That way, each drop of water adds. So first responders, you have to remember, if they're living in that hypervigilant world or fluctuate there a lot, they are going to always be at a roaming simmer all the time. So you never really know what that last drop is going to be. So again, it doesn't have to be a major, large event actually that affects them. It can be something smaller. It can be the fact that their spouse or their friend was supposed to meet them for lunch today and the person didn't show up. And oh my goodness, now they feel like the whole world has fallen apart and they don't understand why. So for them, we're looking at all this cumulative stress. We're looking at everything that they've been going through for their entire career. It's led up to this point usually. So with cumulative stress, we look at the internal and external factors. Another major thing, not only for first responders, but people in general, is disillusionment. Think of disillusionment as a contract. Myself today, as a contract, entered into contract to do this webinar. I entered in with some expectations, knowing that you all would have some expectations. It may or may not go as I think it's going to go. And that could be good and that could be bad. But I entered into a contract. People enter contracts all the time. They do it going to school. They do it with their jobs when they get hired. They do it with getting married. They do it with having a baby, all sorts of things. But if you look, most of the things we enter into contract don't end up being exactly what we thought it was going to be. So for these people, in addition to just regular you and I, we start something thinking we're going to get somewhere and it doesn't necessarily happen. That's why when you see mental health wise first responders, they tend to start to have issues around age or year, I should say, year 17. Between year 15 and 17 of being on the job, when you think that they're now starting to look towards retirement, they're now starting to look towards moving forward, that's when they struggle. That's when they start to have trouble because they've been at it now for 15, 17 years. And to move forward is really hard and it feels exhausting to them. They may have thought they'd gotten a promotion and they didn't. They may have thought they'd get a good case that they wanted and they didn't. And none of it is due to the fact of that they failed or they weren't good enough. It could all be timing, could all be age, it could all be system, it could all be money. So these are the things when we talk later about EMDR that we can help with them because EMDR is all about changing the illogical beliefs that we have about ourselves to make them more logical. It allows us to now see the positive things in events instead of just the negative. You add that to this compassion fatigue and burnout that a lot of people have, the general public has, the everyday person has. And then you add first responders who are going call to call all day long, who are going to perhaps a car accident in which somebody passed away, to then 5 minutes later, they're getting called to go navigate a dispute with neighbors over who put the grass clippings in whose lawn. And then you wonder why sometimes they're annoyed and sometimes they have short-tempered and they have difficulty communicating. Not right, not giving them excuses, but they have this fatigue. They have this burnout from go, go, go with nothing of stopping. There's no off point. You add that to all the trauma that they've seen or the vicarious traumatization that they've heard, and there's a lot. You add that to then the personal trauma that we talked about a minute ago with the childhood stuff, it is huge. If you look at PTSD statistics, your general population has a PTSD diagnosis of about 3.5%. 3.5. Your first responders, well, let's talk first. Your vets, who a lot of people think PTSD is only around vets, your vets have about 20%. Your first responders have 52% higher PTSD rates. And if you look at who is top for PTSD rates, first responders then is top at 52%, vets is at 20%, and who do you think is third in line? It's trauma therapists, people who have that vicarious traumatization, people who are sitting there and listening to people's trauma day in and day out, and who need to actually work on their own work-life balance sometimes and make sure that they're still okay, make sure that they're healthy, they're taking care of themselves. And so we have all these things that are in this struggle bus, all these things that are moving forward. There was a nice statistic that came out back in 23 that I thought was interesting. And this was a research study that they did of 433 first responders. And it is solely self-reported. But with this, it shows you the percentages and the people that sought out treatment, thought about seeking treatment, and some who are actually on meds. And if you look, the medication rates are higher, which is actually probably a good thing. First responders aren't so nervous now about getting put on medication. They're starting to learn like it's okay. They may need it for a short period of time. They may need it later, all depends. But they're able to move forward in their life and they're able to start to gain that resiliency and get help. But the piece about seeking treatment and getting it is huge. So those percentages on the side, those are the percentages of who had completed that survey out of those 433 people. So it gives you just the percentages of the different types of people. And again, this one specific research included DOC. So it's got DOC in there along with your police, your fire, and your EMT. So if we look at problems, right, we have this whole co-occurring treatment, and all of us have seen this for years when we go through our books, we go to conferences, we talk about stuff, everything is very person-centered treatment. And we look at, looking at the person, we have to look at the mental health as well as the addiction. It used to be back in the day, even when I started, back in the day where you would tell people you're not going to treat their mental health if they're not sober. We used to tell people that. You have to get sober before we'll treat your mental health. I look at that now and I'm like flabbergasted. That is absolutely outrageous. You have to look at both. You have to expect that your mental health will start to go up and down as your addiction goes up and down, and vice versa. So you're looking at the whole person. You have to look at that reward center. We're not going to go into all this brain stuff, but for people that like the brain, you get to see that there is this whole reward center that is in the brain. The brain striving to feel better, the brain striving to have more pleasure, to have less pain, and to be able to just feel better, right? Who the heck doesn't want to feel better? Whether it's a backache, whether it's a toothache, whether it's a headache, you want to feel better. What they're learning with PTSD, with trauma in general, is that people can have regular medical problems, right? You can have IBS, you can have back problems, you can have migraines, you can have all sorts of stuff. But what we're learning is that as trauma increases and the stress response increases on the body, so does those symptoms. And so we start to feel worse. We start to feel worse over and over again. So you will notice that people's symptoms will increase. For people that like scans, I put a few scans in here just so that you can see the depressed mind versus the non-depressed mind. I use this a lot when I'm trying to show clients, the ones that sit there in front of me that say that they can will the depression away. I can make it go away. I can make my PTSD symptoms go away. I can make all of this leave. You can't be willing it away. It doesn't work like that, unfortunately. These people have lack of motivation. They have lack of drive, right? Their appetite increases, decreases. Their sleep increases, decreases. They have isolation. They start to eventually feel hopeless and helpless, which we never want people to feel. We want to interject and help before they get to this spot. So it's a very difficult thing, but it shows them that your brain is actually changing. And sometimes for some people who are visual, it's helpful to show them that the brain's changing. Same thing goes for anxiety. If your anxiety is increasing, if you're not sleeping well, your anxiety is going to increase. If you're using substances, your anxiety is going to increase. All of these things have huge changes for people. So as this increases and the paranoia starts to come out of anxiety, people feel like they can't shut their brain off. They're excessively worrying. They're excessively upset all the time. Another symptom of PTSD. So while PTSD has a very large criteria and you have to meet a lot of things, these symptoms that are here that we've been talking about all play a part in coming to that conclusion of a diagnosis if needed, if it comes up to it. So you have this and you have all these different things, which then with the anxiety, as we talked about a minute ago, can have that increased pain, that increased somatic complaints. Those are those people that you think that they're getting better. Medically, you check them, you give them every MRI, every CAT scan, every whatever test you can name, and yet they're still reporting that they don't feel well. They're still reporting that they feel sore, they feel upset, they feel painful. All of that stuff is a result because of their mental health and how they're doing with that. Then to look at the PTSD brain, you get to actually see the differences. So that window of tolerance of what we see for behaviors with the agitation and the irritability or the despair and the hopelessness, that's what we see physically. But actually, psychologically and medically, you see changes in your brain. You see it actually changing. And when we look at EMDR and we look at the treatment for EMDR, that PTS brain versus no PTS brain is what you get when you actually do EMDR treatment. So you have this increased impulsivity that I said, the hyperarousal, the inability to shut off, all of those things that start to come up. You then look at substances. Now, different people use different substances. I always tell my clients, I'm not the alcohol police, I'm not the cannabis police, I'm not any of that. But I'm going to tell you what's going to be helpful for you or what's not going to be helpful and actually hurtful. So when we look at caffeine and nicotine, that's one of the big things I want to stress about. Nicotine, everybody's doing the Zyn packs. Everybody's using nicotine. Caffeine, these energy drinks. I teach at the academies and they laugh at me and they call me the energy drink Nazi because I am on it with energy drinks. And it's not because of the caffeine. People think that the energy drinks are bad for you because of caffeine. It's actually not the case at all. Yes, it has a high caffeine count. However, I would rather have you come into my office with a double espresso in front of me than an energy drink. In the last few years, and even more since then, you have had admissions double. In the last 5 years of the emergency rooms, they have quadrupled for people admitted to the emergency room between age 20 and 35 due to energy drinks. They're coming in due to heart attacks and psychosis. And that's because the caffeine level in them has such a high diuretic. And if you know diuretics, you know that that means that you're going to pee a lot and you're flushing out your system. So if you're flushing out your system, your electrolytes get off, your salt gets off, your potassium gets off. And for those of you that don't know, your potassium is what controls your heart. It makes your heart constrict and contract. So if your potassium's off, you're going to have a heart failure, which is why they're ending up with increased admissions into cardiac distress. And your salt, everybody would like to think that, oh, high salt is high blood pressure. Low salt may be helpful. It's not. Low salt actually causes psychosis. And so what we're seeing is a lot of first responders who are working these obscene amount of hours, keeping up this high, fast pace, and they are doing a lot of energy drinks. I just had another person who came through who was acting kind of suspicious, wasn't doing so well at work. Department thought they would be helpful and took them home for the night so they could get a rest. What they didn't realize is they left them home alone. And he ended up getting into a verbal altercation with a roommate, which ended up being domestic because it's a roommate. They ended up threatening. They had threatening charges. They got arrested. Because they were acting so paranoid, they got shipped to the psychiatric emergency room, and they then were stuck there. They lost their job. They had their gun taken away, and all of it because they were doing 2 to 3 energy drinks a day for 2 weeks. If you look, Canada has actually banned energy drinks. They are illegal. They have banned them for the last year and a half. So I tell all of my officers, all of my clients, if I had one thing that they stopped, it would be that. We know that the alcohol is not a good thing to do. We know that it's still vastly used. It's easily acceptable. It's accessible. People think it's okay. It's legal. But we know causes high blood pressure, causes liver disease, causes digestive problems. Not good at all for people. Then you've got your prescription pills. You are going to see a very, very also high level in first responders of prescription pills. And that is because they are being prescribed from their primary care. A lot of primary care doctors right now want to so-called help the first responders. They want when they come because their knees banged or their shoulders banged or whatever's banged up for chasing that bad guy or, helping somebody on the roof or whatever. They want to help them. They hand them a pill and they hand them a prescription to go get their physical therapy. The problem is none of them go get physical therapy. Physical therapy offices aren't open when they need to be open. They can't get to them. They're closing. The offices are closed and they never go. So they end up going back and they get another prescription. You then now have marijuana and cannabis products used very much so in first responders. And that's because now, since we have a larger legalization, and I know different states have been at different points. Out here in Connecticut, it's been fairly new over the last couple of years. Huge increase. We've put limits on our police where they have to get tested every so often now, but we don't with our fire and our EMS. I have one particular client I can think of right now who uses THC gummies every day, all day long. And they are on the rig of an ambulance treating our loved ones. They're also using alcohol the second they get home to deal with the PTSD symptoms. And they have convinced a nice primary care doctor that they now need testosterone because they need steroids, which is another big one that they don't talk about, but is huge in first responder world. Thanks to telehealth, this particular client not only has the alcohol, the THC, and the testosterone, he is also getting a second dose of steroids from a doctor in Florida via telehealth and a third doctor in Arizona via telehealth. So the doctors don't know about each other. There is monitoring programs, right? The PMP program monitors what clients get and the pharmacies keep track, but nobody checks those on a regular basis. So you have all this going together. You then look at the brain and how it changes for alcoholism. You see how the gray matter and the white matter changes, how it actually changes the brain. Just like a TBI or an ABI, it changes the brain. The cannabis, it's not to say that nobody can smoke marijuana, use gummies, whatever. However, cannabis, again, is also a depressant. So if you're already depressed, if you're already struggling, if you're already having issues, you're going to have even more issues if you start to utilize the cannabis. We start to look at different formulations and different treatment techniques. We've got individual treatment, we've got group treatment, we've got medication management. I put a list of a whole bunch of different treatments that are here. And these are all wonderful treatments. They all are successful. They all do very great work. But I'm going to tell you that N1 on the bottom, the EMDR, that is your number one treatment right now for trauma. It has been around forever. It works. It is the only one out of all of these that the statistics and the research has shown that once you work on a topic, whether it's a topic of a very bad officer-involved shooting or a car accident, or it's just the topic of I'm arguing with my spouse over who's going to do the dishes tonight, and it really frustrates me, annoys me, and makes me feel like I'm not good enough. It doesn't matter. It fixes the problem and makes it go away. So with it, they're showing a 60% piece where 60% of people who are diagnosed with PTSD can have that diagnosis completely removed. And others can have it changed and diminished because it's on a spectrum level now. You can have it removed. So clients that you have that are having flashbacks and isolation and triggering and all of those things, it can actually fully go away. And the reason is because they're looking at the brain differently with EMDR. With the brain, they're realizing that you need to reset your brain and your body. You're looking at one side of your brain that's intellect, that's always trying to figure things out, figure out why I did this, playing the woulda, coulda, shoulda game. And the other side of your brain that's always emotional, that's trying to work on the emotions constantly. Why do I feel sad? Why do I feel angry? Why do I feel agitated? All of those things. And it gets them to reconnect. It gets the puzzle pieces to go back together. So what they say is that when trauma is locked in your brain freezes. Your brain stays on one side of the hemisphere or the other, but doesn't go back and forth. Thus, why the EMDR that has the eye movement within the name is about us using eye movements to reset that brain. So you're going to reset the brain by doing eye movements while people are awake, while they are here, while they are in front of you. And you're going to work on that trauma while they're awake. So for those of you that wear a Fitbit like I do, I don't have my phone attached to my watch because it would go off 24/7 and it would drive me crazy. But I do keep track of it for my sleep and for my exercise. And when I look at sleep, I look at that REM sleep. And for those of you that remember back in school, REM sleep's where your eyes would move really, really fast back and forth. Well, again, they've realized that whatever you do during the day, whatever problems you solve or don't solve, tasks you complete or don't complete, your brain files them into that piece of the brain to make them a stored memory. However, if your brain doesn't have that back and forth, it doesn't get filed and it gets stuck. So with that, when your mom, if she was anything like mine, used to tell me, Tabitha, get your butt to bed, go to bed, and in the morning, you'll feel better. Whatever's bothering you in the morning, you'll feel better. They realized that that was 100% true. You would actually feel better if you slept because your brain was healing. It was fixing the things that it needs to fix. So that's what we're going to do. You can see another brain scan where it shows the overactivity, somebody that has PTSD versus somebody that had it and it's now gone. Look at where it goes back. It goes back to normal. People can live normal lives. They can go through the most horrific thing and come out feeling stronger and better than they ever did before. And that I see every day. So again, you're just looking at that brain balance, that back and forth. With EMDR, we're looking at logic versus illogic. Why do we constantly know that we did a good job at something, know that we succeeded, know that we did great, but we illogically feel that we failed? That's the difference. We're trying to make those connections to move them forward. So by doing that, when we have that disconnect, we're saying that people's coping skills are not together. They're not working, they're not moving forward, and they're having a disconnect. So with it, when we talk about response and resiliency and recovery, we want to use different things that work. We want to do CISM responses, which is, critical incident stress management. We want to give people in the community, everyday people, whether you're nurses, your doctors, your teachers, your electricians, your plumbers, whatever. If they have a critical incident, we should be doing responses. We should be doing diffusings and debriefings. We're doing a lot of work with peer support now. I do trainings for people all over Connecticut and all over the Northeast, really, on peer support. And a lot of first responders are starting their own peer support programs within their departments. But we have to look at follow-up, and we have to look at consistency with it, and we have to look at training. Depending on where they're trained, it can be very, very different. But we know that it's successful. We have that, and then you add the kind of regular, as I call it, clinical treatment, whether people are going through their insurances to get treatment, EAP, workman's comp, whatever it is, they are seeking out treatment. So we look at the statistic. Now, this stat is from a long time ago. It's from 2015, but I thought that it was important to show because it shows when you're looking at these CISM responses and these EAP responses, shows the yellow, people saying how very helpful it was. And what this makes me happy about is that this was in 2015. People are even more apt to go get help now. They turn and they seek out services more now than they ever did in the past, which is helpful. So when we look ahead, we look at recruitment, admissions, we look at putting programs together for departments for people. When I talk about peer support groups, it's not only for my first responders. I do it for my healthcare workers. We just had in Connecticut here, we have, the big power plants and electric boat. We have people from there. It's getting your agencies, whether it's a healthcare agency or whoever it is, getting them to buy in that we need to take care of each other. We need to support each other so that we can all feel better and move forward. So looking at that, we look at a team of creation of people that are going to help teach. We look at psychoeducation so that everybody's informed on mental health diagnoses, substance use diagnoses, all of that. And in Connecticut, I was actually lucky enough years ago to be part of a DOJ grant with a bunch of first responders. And we actually created the one and only first manual for peer support. And it's the manual we use in Connecticut, and other states around us come now to take our training so that everybody is on the same page. So you want everybody to understand when you say a word or a lingo or something, that everybody's speaking the same language. So with that, we have everybody coming together to respond in a holistic way with only the best intentions for everybody. So with that, obviously confidentiality is huge. Likability of who's on these teams. You can't just raise your hand and say, hey, I want to be part of this, because we all have our own stuff going on. And it may or may not be a good time for me to be on this. It may or not be a good time. And we want to make sure that consistency and follow through is there. And I think that goes to play in general with everything. When we're looking at all of this for resiliency, for compassion, for trauma, we want to have compassion for ourselves. We want to give ourselves some grace and some gratitude. We want to give our clients, our patients, our citizens, however you look, friends, family, all and above, some compassion, some gratitude, and help to build up their resiliency. So I hope that this has been helpful. I wanted to kind of go through, answer any questions that you have. I feel like all of this is a lot. I feel like all of these different pieces, I could do 8-hour segments on all of them individually. And so, again, if there's anything that's ever needed or people want, I would be glad to help. And if you want to become a peer support program, if you want to be able to help people in a different way than you do now, because it is a very different way, please feel free to join, feel free to come. We would love to have you. And I just thank all of you for all the great work that you've been doing. Everybody has a different role in helping to support each, again, member, patient, client, however you refer to people. We all have a different role, and I think they're all equally as important. So I'd just like to thank you for having me. And if there's any questions at all, I'd be glad to answer them.
That's fantastic. Thank you so much, Dr. Majorano. And now we will definitely switch over to our Q&A. Let me just get this up on the screen for everybody. Okay, fantastic. So like I said, we will shift into our question and answers. Please be sure to submit them using the Q&A feature within the Zoom dashboard. And we would appreciate it if you could scan the QR code you see on the screen and complete this session survey. You'll want to select the PTSD webinar in the dropdown. It'll take about 2 minutes to complete our survey. So in the meantime, let's jump over to our questions. So one of the first ones we have here is, could you detail out a patient's treatment course for PTSD?
Detail out their course of treatment for PTSD. I don't think
and how many treatments, I guess, would be needed for one?
Okay, sure. I think that is kind of myth-like in a thing. It's kind of like people that want to sell this EMDR. You're going to read a lot of people put on their website, hey, I can fix people in 3 sessions. I can fix people in 6 sessions. It's not really like that. The newest stuff that I've seen taken out is they're saying that if you have somebody who comes for a trauma, for a PTSD, for a traumatic event, that you could sit there and literally talk about that event for a year or 2 in talk therapy. You can talk about how they think they failed, even though their bosses, their supervisors, everybody else has told them a wonderful job they've done, and they still think they've failed. And as a clinician, you're going to feel like you're beating a dead horse because no matter what you say, you can't convince them. What they say now is that in that talk therapy of a year or 2, you can actually fix the problem and get that person to not feel like they failed and actually feel like they were a superstar and they did wonderful and they did great in about 3 months. So I never promise anybody 3 or 4 sessions. I never promise them anything. But when I look at with PTSD in particular, especially first responders, you cannot just jump into the reprocessing part of EMDR. You cannot just go straight for the trauma right out of the gate. You have to prepare them. And that's why phase 1 and phase 2, because it's an 8-phase model, is all about preparing them, learning to help them ground, learning to help them stabilize, learning to help them state change. And so that's going to depend. One client may have really good resources and only need a week or 2 to do that. Another client may need 3 months just to learn how to regulate their body and be able to feel okay in their body, so that now when I disrupt them by doing the reprocessing, as I'm going to do, and I make them uncomfortable for a little bit, they'll be able to actually tolerate it. So EMDR is never fun, but it's definitely should be tolerable. So the treatment planning, the length of time is going to vary based on the client, but don't think, and this is a main myth, I think, don't think that just because somebody comes to you and that event is so traumatic and so gruesome and so bad that it's going to be forever. And yet that person who has less gruesome or traumatic is going to be quick. You got to remember all the kids stuff. You got to remember all the past that led up to it and what our brain has underneath, because the brain still has all those things underneath that they need to work on and they need to fix. And so you can't just say, oh, you're going to be a quick one. Oh, you're going to take longer. I've been surprised many a times.
Well, that's great. And then what kind of exercises do you give them to do? And do you use any programs for these exercises? So something they maybe could do on the computer?
So a lot of exercises that we do, I tell people, don't forget your regular clinical skills you've done forever. I'm a big guided imagery person. I use a lot of guided imagery. I use a lot of meditation, mindfulness, grounding skills. Heck, I've been known to sit there and do a couple of yoga poses with people in the room if they have to. Really, especially whether you're prepping for that EMDR or you're just treating patients in general, you want to find what works for them. So if going to yoga works for them, do it. If working in your garden works for them, do it. Get them to then notice the garden different. Be mindful when they're in the garden. Feel the salt on their hand, not the salt, the sand on their hands. Feel the earth. You know, if you're an exercise person, don't just run to run today. Run to feel the feet hit the pavement. Run to actually be connected with the earth so that you have that mindfulness piece.
Yeah, fantastic. The questions are just coming in now, so I think we might try and do like a rapid question kind of.
Sorry, that's okay. I'll talk faster.
No, that's okay. So if the stressor or trigger of a patient's PTSD is a constant presence in their current life or environment, meaning there's no way to achieve complete physical separation from it, do you still consider their PTSD to be curable or fully resolvable? How does treatment shift when avoidance of the trigger isn't an option?
That's perfect. That's not an issue. You can't always avoid a trigger. So in quick words, look at a domestic violence client who's not ready to leave their perpetrator yet. They're not ready. They're never going to be in full health before we have to start EMDR or any other treatment. So I always tell people we're looking for progress, not perfection. If my person can utilize those skills a few times in between sessions, if they can utilize them sometimes, even if they don't fully feel better, but they feel a little better, we've got progress. And that means I can move forward and start to treat them, especially with the reprocessing.
Yeah, great. Do you have any specific treatments you recommend for grief trauma?
EMDR, to be honest with you, I have worked with so many people that have lost their children, have lost their spouses, have lost, partners, whatever. And it works amazing. Absolutely amazing. Because again, even with a grief, even if you have, let's say, your grandma who died of natural causes at the lovely age of 99, who got to fall asleep in her bed and never wake up, and it was absolutely perfect. What EMDR is, again, it's about working with the illogical. So my goal with him or her is to figure out, what are you blaming yourself for? You know you shouldn't blame yourself. You know this has nothing to do with you. You know this is old age, but you're blaming yourself for something. So when we figure out what that is, now I can go in and fix it. And you are going to have such relief from the grief. It is amazing. It is just amazing.
That's amazing. And can you work on Zoom with people?
You can. So especially when COVID hit, they actually started doing a lot of EMDR on Zoom. At first, it was funny. At first, they came out and told everybody, don't do any EMDR, don't do any, we don't know what's happening. And then they learned. And so what we do is a lot of EMDR is about following your fingers. So you're going to do it on the Zoom screen with your clients. I would be rotating the screen so you don't see me anymore. You'd be just following my fingers instead. But then there's also a computer program, whereas while you're on Zoom, I'm on Zoom, I give you a link and you could open up this program, and we call it the bouncing ball. It's going to have a ball that goes back and forth across your screen, and you're following that. So there's definitely ways to do it on Zoom. They are saying that, it's just as effective. Like I said, I train people on it, teach people on it, along with, HAP and the Institute, who are the two biggest trainers. And we train clinicians how to do it that way. It is successful. Yes.
Okay, great. So I think that we are just before the hour now. So we want to thank you all for joining MLCC's fourth and final Injury Insight webinar of 2025. A playback of this webinar will be available within 48 to 72 hours. Additionally, we ask that you take the time to complete the webinar survey if you haven't yet. And for those who attended live, please anticipate your certificates of completion within 48 to 72 hours. And thank you again, Dr. Majorano. We know that our attendees enjoy learning from specialists like yourself. And our last plug of the day is our first 2026 Injury Insight will be held on March 18th with Dr. Sean Rocket, total hip and knee replacements, the potential complications, and the long-term needs of the patient. Keep an eye out for more information and registration in the new year. And with that, we will conclude today's webinar. Thank you again for watching, to our hosts, Dr. Majorano and Cynthia, and we wish everyone a safe and happy holiday season. Thank you so much.
Thank you so much. Thank you, everybody.